Good morning, everyone. And I'm going to talk about how useful echocardiography is in decision making about in complex two ventricular repairs. Now, we are increasingly performing complex repairs in our country, and we are also reducing the age at which complex repair is being performed. Looking to the future, we are going to discuss about the possible roles of usefulness of 3D models and virtual reality in decision making in these models. Not all of us have access to 3D models and virtual reality. So looking to the future, we also need to have some sustainable way of imaging them to ensure that we have optimal repairs. The challenges usually faced in complex two ventricles are the relation of the arterial trunks to the VSD and abnormal veno-atrial connections, both of which can be easily made out by modalities like CT and MR. But AV valve attachments are one modality which cannot be made out by other imaging, one abnormality which cannot be made out by other imaging modalities, and echocardiography is going to be the only modality which is going to sort that out for us. So because it's an imaging session, I'm going to rush through the other part and focus only on the imaging here. This was a retrospective case record analysis over the past 2 years, where a single pediatric cardiologist performed all the echocardiograms on a Philips Epic ultrasound machine. We had a total of 24 patients who were referred for potential two ventricle repair. 2 had previous palliative procedures before we evaluated them. 1 had a previous complete repair and had a complication related to the repair, whereas 21 did not have previous repairs. We deemed 23 patients to be suitable for two ventricular repair. 1 had a very small LV, which we thought was not needed only single ventricular palliation. In these 23 patients, we recommended an intermediate palliative repair before a complete repair in 5 patients, whereas 18 had a direct complete repair. And subsequently, all of these patients have had their full repairs. So there was no deviation from the pre-operative plan in any of the surgeries. We had 2 deaths in this entire cohort, and pre-discharge, and we had 2 late deaths, one of which was unrelated to the heart condition. None of the patients at last follow-up are on any heart failure medications. 2 are on anti-PH medications, and 2 have had post procedures after the surgery. The patients under palliation, a 4-month-old with CCTJ, VSD, and arch obstruction, where we did a PA band with arch repair, a 3-month-old with a remote VSD DORV, whom we initially palliated with a band and then a complete repair at 1 year. We had a baby who presented at 1 year with very low saturations, who had CCTJ, VSD, PS, and abnormal mitral valve attachments. We did a superior pulmonary anastomosis and then a subsequent double switch. And we also had a newborn with CCTJ pulmonary atresia who had a BT shunt and then a repair at 6 months. So this is an entire cohort. I'm going to focus on some cases. We recommended additional imaging in 1 patient, a CT, which really did help with the procedure. CT was also performed in 11 other patients, but it did not change the surgical plan based on echocardiography. So the initial assessment was either in the newborn period or up to 32 years of age. Complete repair was 3 months to 32 years, but this was skewed by 2 patients who are 10 years and 32 years respectively. The median age was only 1 year. The anatomy was discordant AV connections in 9, TGA VSD pulmonary stenosis in 5, DORV in 6, isomerism of some kind in 3, and AVSD in 4. Some of them had a combination of these things, which is why the numbers won't add up. The challenges were abnormal veno-atrial connections in 2, VSD to great heart relationship in 6, and abnormal AV valve attachments in 7. We had 2 pre-discharge deaths, as I said. One child actually arrested in the ward prior to the planned surgery and had to be taken up for emergency surgery with a lactate of 23 pre-bypass. He had a prolonged ICU stay and died later. And a TGA with multiple VSD also died while weaning of CPB. There are no heart blocks or pacemaker implantations. There was 1 chylothorax in a post-hemimustard with Rastelli, 1 prolonged effusion after similar surgery, which resolved by 4 weeks, and 1 SVC obstruction after Glenn takedown, which was treated with SVC stenting. 1 child with severe RPS stenosis and probably a Glenn which is not doing very well. As I mentioned, no one is on heart failure medications, 2 are on anti-PH medications, and 5 children are on aspirin. So these are some of the AV valve attachments which are made out, abnormal AV valve attachments, which only echo can show you. I'm going to show some loops which will show it much better. So this is a patient with a DORV and a remote VSD, almost an inlet VSD. You can see that there's an abnormal tricuspid valve attachment to the subaortic outlet muscular septum. And this is better seen on the subcostal view. So this is a tricuspid valve attachment to the subaortic outlet muscular septum. So the surgeon, while placing the patch, actually removed the cord and attached it to the patch and ensured that the tricuspid valve was not compromised. This was again a TGA VSD PS. You can see abnormal mitral valve attachments to the crest of the intraventricular septum and slightly to the right ventricular aspect. So the surgeon, while taking the patch, ensured that the patch started beyond this caudal attachment and ensured that the mitral valve was not compromised. So the still images shows you this is where the attachment is, and the patch is taken up beyond that mitral valve. We also had one patient with accessory AV valve tissue, again, double outlet right ventricle with normally related great arteries. But with imaging, we were able to convince the surgeon that this was all accessory tissue which can be removed and that the mitral valve will not be compromised by excising this tissue. And this was the post-repair echo. You can see that the LVOT is completely clean. There's nothing obstructing it. So I'm going to showcase some challenging cases. This was a patient who was wrongly labeled as double inlet left ventricle and inoperable at 11 years of age. Actually, he had crisscross AV connections and supra-inferior ventricles. So you can see the RA and the RV, and then the LA and the LV at a completely different plane. So the LV was inferior, RV was superior. So this loop shows this LA, LV, RA, RV, and there's double outlet right ventricle with both the great arteries arising from the superior RV. All the child needed was a VST closure, nothing else. Again, this was a very challenging patient whom we faced, discordant AV and VA connections, VST severe pulmonary stenosis who previously underwent a Glenn. So the challenge here was abnormal mitral valve attachments. You can see the mitral valve going across from the LV to the RV here. And there is significant, even though there's no obstruction here, there is significant tissue in the LV to aorta pathway. And when we did a sort of modified Paston long axis, we saw that the attachments of the mitral valve cords were to a papillary muscle, which was in a completely different plane to the interventricular septum. And 3D also shows some degree of overriding of the AV valve orifice beyond into the right ventricle. So this patient underwent a baffling procedure where you can see that the VST patch actually is on two planes. So there's one plane, and then beyond the AV valve, beyond the abnormal papillary muscle, the surgeon had to devise a different plane to connect it to the aortic valve. So this is probably the only view where we could see the two planes sort of in a single frame on 2D. And there was absolutely there was no significant LV outflow obstruction despite the repair. So only because of the echo were we able to plan this procedure in detail, and the surgeon could go in with an idea of what he needed to do. Again, an interesting patient with isomerism, whom we operated at 5 months and 4.1 kilos. You can see IVC and aorta to the left side of the spine. So the IVC as well as all the hepatic veins drained into the left-sided atrium. There was only a left SVC which drained again to the left-sided atrium. We have a long sweep to confirm the systemic venous drainage. So you can see the IVC going into the left-sided atrium. And as we continued sweeping upstairs, you can see the SVC also joining into the left-sided atrium. All the pulmonary veins were joining to the right-sided atrium in an unobstructed fashion. The anatomy was essentially AVST. So there was a primum defect, a common AV valve. The inlet component was small, but it was extending into the outlet septum as well. And this patient underwent an atrial baffling procedure, AVST repair, and DORV routine. You can see the SVC baffle is essentially unobstructed. The IVC baffle is unobstructed. There was mild plus MR, which was all related to a cleft. I have two more patients, 1 year old with who had underwent the PA band with arch repair, who had a very large VST. It was very difficult to make out the plane of the VST on 2D echocardiography, all on 3D.
Hello.
And in this patient,
Can you please wind up?
Sure.
Because your time is
last case. So 3-month-old with symptomatic heart failure, CTJ with VST, a very large VST inlet to outlet essentially. And here actually 3D echocardiography helped the surgeon to understand how the VST is going to look through the tricuspid valve. He underwent a double switch with the VST closure. So in conclusion, a focused echocardiogram is probably the only investigation you need to do in most complex CHDs. AV valve abnormalities cannot be picked up by any other modality of imaging. And 3D modeling, it has a definite role, but probably a definite role is only in a small subset. Thank you.